published, which was published very recently in 2024. And let us have a look at the background. So, as we know, myopia is a global health concern, and almost half of the world's population is expected to become myopic by 2050. And we have seen in last few lectures that emmetropization is one of the pivotal processes by which the eye adjusts its growth to achieve clear vision. But this is the same process which also causes axial elongation in cases of myopia. Now, there have been many studies that have shown that peripheral retina may actually play a key role in controlling eye growth. In the lecture by Dr. Jitendra sir, also he highlighted a few animal studies in which the fovea was ablated, and still the eyes of the infant monkeys kept on progressing, and axial elongation could not be prevented. So there is sufficient evidence say that peripheral retina has a key role in emmetropization. Also, talking briefly on the role of the choroid, there have been several studies to prove that short-term changes in the choroidal thickness, which can also be measured as changes in the axial length, are assumed to predict future eye growth. In fact, choroidal thinning predicts axial elongation in the future and precedes it, as well as choroidal thickening is said to have a axial growth inhibitory effect by downward cascading signals. So, what was the need for this study? There have been previous studies, and there were already technologies in the market like BIMS and HALT lenses with a proven inhibitory effect on myopia. But the effects of these were variable and the reasons were not clear. So more research is needed to map out the most responsive retinal areas and also determine which type of retinal image degradation or defocus would be the most effective in controlling axial elongation. So the objective of this study was to identify a specific area that detects defocus and induces axial eye shortening, which is by stimulating the inhibitory pathway of emmetropization. So an experiment was designed. 20 young adults with a mean age of 28 years, with all having binocular single vision, were taken. Now I'll just move on to the picture. So the right eye of these patients, in front of the right eye, +3 diopter lens was placed, which induced a myopic defocus in front of the right eye, and the left eye was emmetropic. Now, a custom-built infrared tracker was placed at 50 millimeters from the left eye, which continuously tracked the gaze of the left eye. And all these participants were made to look at a 65-inch TV screen, which was placed 2 meters away from the eyes, and a moving picture was showed to them. Now, what this custom infrared tracker of the eye did is, it continuously at every point of time it tracked the movement of the eye, and corresponding to the fixation point on the screen, it applied a gray patch which limited the spatial information to the eye. So basically, with the right eye was seeing a total blur screen because a plus lens was placed in front of the right eye, and left eye was seeing a clear picture. Now, axial length was measured at baseline, at 20 minutes, and at 40 minutes in lens star. And this was done for all the participants at the same time of the day to avoid any influence of diurnal variation. Now, four patches were basically tested, and full field defocus was used as a control. So I'll explain this with the help of the relevant diagrams. So, first is, as you see on the left side of the screen, first was a foveal patch, in which a 3-degree eccentricity foveal patch, gray patch, was applied. So basically, the information from the center of the visual field was omitted. The second patch which was tested was a 3 to 9 degree eccentricity annular patch. So the fovea was spared, and the gray patch was applied, covering from 3 to 9 degrees of the retina. The third patch which was tested was a foveal patch in combination with an annular patch with with 6 to 9 degree eccentricity. So in case of the third patch, only the field between 3 to 6 degrees was shown, and though that beyond 9 degrees was shown. The other spatial information was limited. And last was a full field patch where only the annular area between 6 to 10 degrees eccentricity was exposed to the positive defocus, and rest all the information was uh, covered using a gray patch. Now coming to the results. So when there was no gray patch which was applied, that is a full field defocus. So basically in that case, the right eye was looking at the screen with the +3 lens in front of it, and the left eye was looking at the screen directly. It was seen that there was significant action after 20 minutes. That is of 10, the average was 10 microns, 14 micron standard deviation. After 40 minutes, this increase in axial length persisted, and it was clinically significant when it was controlled, when it was compared to the control eye. So in this case, the control eye was the other eye of the same patient. So this indicated when the retina was exposed to positive defocus, there was axial shortening, and this axial shortening was of the magnitude of 10 microns. Coming to the first test case, where a foveal patch of 3 degrees was used. So it was noticed that the axial shortening similar to what was observed with a full field. The conclusion was that fovea contributes minimally to emmetropization. Even if the spatial information from the central foveal field was removed, the axial shortening was still similar to what was seen previously with the full field defocus. So the conclusion from this particular patch was that the fovea did not contribute significantly to emmetropization, but the peripheral retina was more crucial. Moving on to the second test case, in which an annular patch of that covered visual spatial information from 3 to 9 degrees was used, and the fovea was spared. In this particular cohort, it completely suppressed axial shortening. What was seen in the previous two scenarios, there was clinically insignificant foveal axial shortening which was seen. So this kind of meant that the area of the retina lying between 3 to 9 degrees was somehow crucial in inducing the axial shortening which was being studied in this particular study. Now, the next in the next test scenario, there was a foveal patch which was applied along with an annular patch of 6 to 9 degrees. So 3 to 6 degrees was spared. Again, the finding was that there was no significant effect on the axial length, went ahead to tell us that the area between 3 to 9 degrees is critical for defocus detection, specifically the area between 6 to 9 degrees. And this was tested in the next test scenario, in which only 6 to 9 degrees of eccentricity was exposed to the defocus, and rest of all the spatial information was covered. And to the surprise, there was significant axial shortening, almost comparable to the full field defocus. So, from all this information, it is deduced that probably the area between 6 to 9 degrees or 6 to 10 degrees of eccentricity was having a comparable effect to a full field defocus, and this may be the sweet spot for regulating the eye growth. The results can be seen in this graph. So in the graph above, you can see that the three lines that you can see inferiorly will start from the line of the foveal patch. So in the foveal patch, we can see as almost comparable to the black continuous line. Just above that is the line in which only the 6 to 10 degrees annular area was exposed to the defocus. So these three have almost a similar effect, which goes ahead and tells us that probably 6 to 10 degrees of retinal eccentricity is probably the sweet spot for axial growth inhibition. And the two lines above that the gray dashed lines. That is shows the foveal patch with the annular 6 to 9 degrees patch and annular 3 to 9 degrees patch, in which there were no changes noted in the actual length. And the graph B shows the control eyes, that is the other uncovered eye of the participants, in which there was again significant.
नहीं आ गया तो दे दो कुछ जो भी है.
So the key findings from the study was real input is not needed to realize shortening with post positive defocus. Because when the fovea, even with the foveal patch applied, the actual shortening was similar to the full field defocus. Second is the retina cannot defocus when the retinal area between 3 to 9 degrees eccentricity was covered with the gray patch. Third is exposing the retinal area between 3 and 6 degrees eccentricity and also beyond 9 degrees had no average effect on the retinal after 40 minutes. And since the effect of exposing the retina only between 6 and 10 degrees of eccentricity caused similar effects as full field defocus, it may be that this area was the sweet spot for the detection of positive defocus. These graphs were particularly interesting because the results that we saw till now were the average changes in actual length. But as you can see here, I would like Dr. Jitendra to elaborate on this further. As you can see here, even with the other test scenarios, the individual variation seems to be very high. Even with the foveal, even when the three, as you can see in chart C, even when the 3 to 9 degree eccentricity was patched and fovea was exposed, there were 2 or 3 patients who actually showed significant axial shortening. Now, this may be due to individual variation in distribution of the cones, which we will see further. And this may also answer the question of why some patients do well with the myopic defocus glasses, but not all. Now, what was the anatomical correlation? So the hypothesis is that there is a high density of S cones in this particular eccentricity between 6 to 10 degrees. Now, these S cones are the ones that are sensitive to chromatic defocus and longitudinal chromatic aberration that is typical for a myopic eye, that is the blue spectrum is focused in front of the eye as compared to the red. This induced transient axial shortening in young adult human subjects. This was already proven in a previous study. Now, these S cones, which detect this blue spectrum of the light, are absent in the fovea and they are evident in the periphery. And there is a very high level of these, high concentration of these at around 9 degrees eccentricity, which gives a high visual acuity as well. Pershio et al. Also showed that the distance, and in this particular retinal eccentricity, the distances between S cones and L or M cones was smaller than that between L and M cones. There may be a sweet spot for the control of emmetropization at the retinal eccentricity, where the S cone density provides a sensitive measure of chromatic defocus, and the L and M cones are abundant enough to compare this image defocus at long wavelength end of the visible spectrum. So this particular area of retinal eccentricity is between 6 to 10 degrees, is where the mix of cones was optimum to detect defocus and have a significant inhibitory signal for the actual elongation. The current study showed that the area around 6 and 10 degree eccentricity would be the conclusion was that fovea was not essential for defocus detection. Peripheral retina regulates axial shortening and likely controls growth inhibition. Even amongst in the peripheral retina, the area between 6 and 10 degrees eccentricity is critical for detecting positive defocus. In fact, in a previous study by Penorius et al., ERGs were also most affected when the blur imposed was between 6 and 12 degrees of eccentricity. So targeting this sweet spot would enhance myopia treatment strategies. The clinical implications, it supports the design of myopic and the concept of myopic defocus lenses, which is used in dim salt and myocare lenses. However, there were some limitations of these studies. First is only circular patches were tested. There have been previous studies that show that there may be difference in the sensitivity between the superior and inferior retina as well. So this was not tested in the study. It measured foveal axial length only. The stimulus was defocus, and the patches were annular, and they were basically blocking spatial information from the eccentric retina. However, measured uh, the measured axial length was foveal. So this was again one limitation. So it is still unknown how these signals travel from the periphery to the fovea. It was a short-term study. Long-term effects are unclear. The sample size was small, and there is also theoretical possibility that the inhibitory and stimulatory mechanisms of hematophysics operate at different retinal eccentricities. What this study tested was the inhibitory growth mechanisms. So future directions, vertical retinal zones, example, superior retina versus inferior retina. As I mentioned, there have been studies that shows that the superior retina is slightly more sensitive to glare and defocus. The retina to choroid signal pathways have also not been thoroughly investigated. And to understand individual sweet spot variability. Uh, as I showed in the previous graphs, even with different eccentricities, some patients responded very differently. So this might influence a customized kind of approach that we need to have, even in when myopia glasses or defocus spectacles are concerned. Thank you.
Yeah, I think this was an excellent summarization of the whole talk. The few things which we can also discuss. You can stop sharing, Minas. Yeah, there are few things which I would say is that, what what they have studied, what they have not said clearly is what is or if they have said, you can tell me what is the age range of these patients. Second thing is that, they did this stimulus, but we all know that, axial length growth will take a long time. Myopia is a chronic disease. There are a couple of similar articles from LVP group where they have told the patients, young adult patients, and told them to sit in blue light, told them to sit in red light. Now, it is very difficult to understand that in an adult patient there will be a small change, and that is why when the graphs which you showed had huge intertest variability. Also, in my own talk on optical options in myopia, we have discussed that, if you see these patients, it is very difficult to know what is the level of eccentricity and whether at that particular point there is any blur is there or not, and whether that particular blur is significant for that particular patient or not. So, as you said, customization would be needed, but customization would be difficult to find out because I tried to include or read about articles on how to measure axial length of different areas of retina, and there have been some work on it where they have tried to measure it with the help of IL master. We can definitely use the peripheral refraction aid, at least in the horizontal axis, to find out what is the diffraction for each patient and to find out which patient is working the most. And that is where I think these people who have started defocus glasses, that is where they have used an idea that after the central 9 mm zone, which is responsible for central 25 to 30 degrees of visual field, outside that they have made sure that there will be a blur of plus 3.5. And so how does it help? Any point which is sensitive in the 360-degree area will be taken care of. So that is the whole premise of these myopia control classes, because it is extremely difficult to agree to the fact that only 6 to 10 degrees of eccentricity has the sweet spot. And Dr. Minaz is very right in concluding that every patient may have a different sweet spot, and there will be a different level of eccentricity for all the way for each and every different patient. And that is why sometimes when you measure their peripheral refraction, it may not be really hyperopic, but it may be hyperopic at some point, and that is where those particular glasses may be working. So the problem with I mean, the study is wonderful. It actually sets in the concept, and it gives you an insight what they are talking about, why they are talking about foveal blur, why they are talking about peripheral blur, how much blur is important, how they created the blur. The study is good. The only problem is that short-term result, small sample size, and lots of ifs and buts. So if you see, there are tremendous hypotheses, and the leap of faith is very high in the study, because they have come to a conclusion that 6 to 10 degrees is the sweet spot, but they have also concluded that it may be different for different patients. So I think that is what we concluded, that what I conclude from the study is that, because I read another parallel study which said that 20 to 25 degree centricity is the sweet spot. I think I quoted that in the video of mine. But the conclusion for us as users, and not really the research people, is that some level of eccentricity, if there is hyperopic defocus, we have to change it to myopic defocus by using peripheral defocus lenses. And why peripheral defocus lenses are working despite sometimes measuring the peripheral refraction, and the peripheral refraction is not coming out to be hyperopic, and still it is working, probably because that particular sweet spot is missing when we are measuring it, and that particular sweet spot is being targeted with these glasses. So that is what I took away from this particular work. We can discuss about the video which I had shared. We can talk and discuss about it also.
Sir, I have a question about the video.
Yes.
So when we do this peripheral refraction, do we do it at the first visit itself or on the follow-up visits when we see the progression?
So you can do it at the first visit. It is much easier to do it in the follow-up visits. I will tell you why. If you do it in first visit, when you are doing the retinoscopy, you can neutralize it, and then you can see what is the peripheral refraction. But if you give glasses and call them again, it is much easier, because now what you are doing is you are neutralizing the center with his glasses in position and just telling them to fix eccentrically and measuring it. So it becomes much easier to measure it that way. At least in my practice, I do that because it becomes easy. Not that you can't, you can measure it in the first instance also. Both ways is fine. We just want to see whether he is progressing or not. If he is not progressing, you are not going to start any treatment. Regardless, his peripheral refraction may be hyperopic. So the only advantage of doing it in the first visit is you can share that information with the patient that, look, his refraction is, he is having peripheral hyperopia. There's a good chance that he may progress.
Okay, sir.
So I have a question
Yes.
regarding to the presentation. So when we are doing the retinoscopy for the peripheral refraction, do we actually neutralize it, or are we just seeing the glow pattern? As in, and do we
We
have
can.
to?
So what we do is, when we used to collect data for studies, we used to actually neutralize it.
Okay.
For your practical purpose, you just want to see whether it is hyperopic or not. So that is a very good point that, and in my talk, I have said that what is the amount of hyperopia we need?
Yes.
See, nobody has any idea. So what they have done is, they have said that even if you have a minimal amount of hyperopia, you should take it as significant. That is what is the current understanding. And myopia is evolving so quickly. See, this particular article which came recently about sweet spot, before this, everybody was talking about going eccentric to check up to 30 degrees periphery. And now it has come down to coming down to 10 degrees periphery. But my point here is that, there are two things. One, as you said, if you neutralize, you will know how much is the hyperopic refraction. Whether more hyperopia, peripheral hyperopia, is associated with a stronger progression, no, not known. Whether this particular more hyperopia in the periphery, whether it is a sufficient amount of blur, not known. But what is known as peripheral hyperopia is a risk factor because it adds to the blur. Whether 20 degree is whether 20 degree is important, whether 10 degree is important, that particular point is still going on. Also, always remember that the original article by Dr. Earl Smith 3 was on infant macaw monkeys. So we are
Yes.
presuming and assuming that whatever is the pattern in that particular those monkeys would be there in humans, and based on that all this peripheral hyperopia is coming. But now that they have done more and more work on humans, one thing is clear, that peripheral hyperopia is definitely something which works. The point is that it is
Right.
definitely responsible for myopic progression. There is no doubt about it.
Okay. So, and also, like example, if I am doing a central retinoscopy, I'm getting a value of say -6.
Hmm.
And if I do peripheral and I'm getting a value say -2 or a -3. So in relation with the central
Plus
refraction, this
3.
is still hyperopic.
No,
Yeah.
no, of
So
course. No,
yeah.
so that is
So
what. Okay, so it is always relative to center.
yes. So I just can't be looking only at the glow because it is going to be a myopic glow in both the cases, right? Because
No, 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 no. So
you have to do it with the glasses on. That's why.
yes, that is
Okay.
the answer to Prajakta's question also.
Okay. Okay.
That if he has
Yes.
glasses, it becomes easier. But if you are neutralizing in the center at -6, you have to use the same -6 in periphery so that you know whether he is plus at -6 or not.
Okay. Okay.
So
Yes.
if
Then
he
I
is
got that. Yeah.
-3, then he will have +3 at -6.
Okay. And any difference between even if I get a hyperopic defocus at say temporally but not nasally, are we still justified in giving him the myopia progression glasses?
So at this point of
Right.
time, we are giving myopia progression glasses to even patients who do not have any peripheral hyperopic refraction.
Okay.
We have done that also, and it works in them also. And then when we read the article on sweet spot, then we realized that probably we were looking at 10 to 15 degrees or 20 degrees, and he may be having a hyperopia at 9 degrees. So
Right.
see,
Okay.
that is the reason that article has lots of ifs and buts. So normally all these hypothetical articles are to be understood, and then you have to wait for clinical evidence, because this particular article is a sort of an experimental setup where they have tried to replicate it in a short time. Normally, chronic changes may not be similar to what they have replicated in a short time. That is number one. Number two is, if you said that if there is a temporal nasal asymmetry, the article from LV Prasad group says that in their particular population base in which they did, they actually found a nasal temporal asymmetry. In fact, in our work also, which we did with our peripheral refraction aid, we found that the hyperopia was different for nasal side and different for temporal side, and temporal side did not always match with nasal side. So not all patients
Yeah.
really had hyperopia here of plus 0.5 and there of more than that, or sometimes there was no hyperopia at all. In fact, there was a myopic this thing, but that was again for fixed 20 degrees or 10 degrees. It would change. It would change, and we may feel that the more eccentric we go. See, one small thing, I think I forgot to make a drawing of that. One thing we have to understand is that nature has carved the cornea in such a way that it also starts to becoming flatter as it goes in periphery. So
Yeah.
that particular peripheral cornea is also taking care of the peripheral retina. So we don't have to. So all the data on measuring the axial length peripheral is also not very great from this perspective, because the refraction may still be myopic or hyperopic in periphery depending on the power of the cornea.
Yes. Yeah.
Because the more
Okay.
eccentric you go, you have to go more eccentric from the cornea also.
Yes. Yes. I got that.
Yes.
Thank you, sir.
So again, one basic question I have.
Yes, yes.
Here, suppose we are neutralizing the center with retinoscopy. For example, if I get a neutralization with -3,
Yes.
so that means for distance, say if I'm sitting at 1 meter distance, then the glass power will be -4.
-4, depending on what is your cycloplegia used. Yes, but you are right. If we are not
Yeah,
deducting for cycloplegia, if you are
yeah,
if you are dilated with atropine, it will be -5.
-5.
हाँ, ठीक है.
So
We
then we
take it
give
like
the
that.
glasses depending on the acceptance of the patient. Suppose patient accepts -5, we
Yes,
give -5.
yes.
And next time when the patient comes with glasses
Glasses.
and we are trying to see the peripheral refraction, that time with the patient wearing -5 glasses, even the center will
+2.
be
+2.
hyperopic. Yes, it will be
Yes.
hyperopic. So
But whether
with that,
the periphery is more than +2 or not, that is what you have to see. So you have to,
so
you
we have
always have
to
to,
like,
yes, yes, you have to neutralize the
yeah.
center, and only with respect to center, you are talking about the periphery. It is always
Okay. So
relative, it is always relative peripheral hyperopia.
okay.
So
Okay.
if in center you have +2, and then you are holding that +2, no, this is a practical tip. It is not for if you want to do if you want to accumulate a research data, then you don't have to do like this. This is a practical thing. You are holding +2 in your hand. You are doing refraction. You have a peripheral refraction. You tell the patient to fix on a peripheral target, and still you have already neutralized in the center. You know this is 0. And then you tell him to fix
Yeah.
there, and if you are still doing, and if you are still getting width, it means that it is more than +2.
Yes. Understood. Thank you.
Sir, I have a question.
Yes, Ramya. Yes, Ramya.
Yes, sir. Sir, if a patient, have you noticed any progression, significant progression in those using these lenses, sir?
See, I must have prescribed around 250 odd lenses. One patient
Yes.
keeps coming back with progression. Except that
Okay.
patient, I have not seen any patient on significant progression. One patient, yes, he had progression despite.
Yes.
So most of my patients would not be on monotherapy, except if I'm doing a
Yes.
particular study for these lenses where we are using them as monotherapy. Bulk of my
Yes.
patients, so my practice pattern is pretty simple. If the patient comes to me, I will not tell him to. I mean, this is not really official version, but
Yes, sir.
this is the practical part. If patient comes to me, I would tell him to use atropine, and I will
Yes, sir.
follow because atropine is cheaper. And at the end of the day,
Yes.
our loyalty is always towards the patient. If patient is a medico, if patient wants to, I mean, this is about once you have documented that there is a progression. Now, once you have
Yes, sir.
documented the progression and if patient is educated, patient wants to start glasses, that is a completely
Yes.
different thing. Because nowadays,
Yes.
patient come for second or third opinions. They have already been told about glasses or they have read about glasses. So you can,
Yes.
so I tell them, fine, we can start glasses. I'm not against glasses, but if patient gives an option to me, I tell them to put atropine. So most of my patients are on combination therapies when they are using glasses. So most of the patients
Yes.
are having very good control with atropine and glasses. If I talk about
Okay.
monotherapy, the patients which we enrolled for most of our studies and research work,
Yes.
yes, there are patients who do progress, and we tell them to keep using glasses and start atropine also. But they will
And
not
sir,
be more than 10 to 15%.
do they tolerate the glasses like
More or less. I think one patient recently came back saying that the kid is not able to tolerate, but
yes.
otherwise they do tolerate well.
Okay, sir. Thank you.
Jitendra, I have basic
Yes, ma'am.
query confusion that there is already peripheral blur in myopia, and are we inducing more blur by giving glasses? I'm sorry, I don't understand that
No, 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 no.
uh,
So there is no.
mechanism.
Okay, so the what so the blur is different. The blur which is there in a myopic patient is a hyperopic blur. We are converting that to a myopic blur. Now, coming to in the practical terms, what does it mean? A blur is a blur.
Yeah.
So what it means
Okay.
is that when the eyeball in periphery has a hyperopic blur, what happens is that
Mm-hmm.
the image is forming at the level of choroid or slightly behind that. The choroid tries to thin out and it gives way to retina. Madam, this is all hypothetical.
Okay. Right.
Whether this
Right.
happens
Right.
or not, nobody knows.
I know.
But this
Nobody
is
knows.
all done on infant macaw monkeys. This is the way of explanation. So what is happening is that
Right.
this is the eyeball, and here it is the fixation is just behind the retina at the level of choroid or
Right.
behind that. The choroid, so
Okay.
they have studied that choroidal thickness starts reducing as the eyeball grows, and the choroid
Hmm.
actually sort of thins out and gives space to retina so that
Hmm.
uh, fixation blur is not there and the image gets clear.
They're not there.
Ha.
Right.
But
Right.
when you make it myopic, the choroid does
Hmm.
not the choroid will not thin, and the choroid doesn't have to do
Hmm.
anything because the image is not forming there. Image is
Okay.
forming anterior to it.
Right. Right.
So,
Right.
so to get that clearer image, ideally the eyeball should constrict. It cannot constrict. There is no way it can constrict.
Hmm.
So it remains as
Right.
it is. Now,
Right. Right.
similar theory has been used by the people who are using low level red light, saying that
Mm-hmm.
because the light has a higher wavelength, it stimulates the
Hmm.
choroid, and that is how
Hmm.
it doesn't let the axial length grow by
Right.
giving
Right.
repeated
Right.
low level red light. Because mechanism in
Mm-hmm.
that thing is also not very clear how red light therapy, but what is the mechanism of action, that is not clear.
Okay.
And you
Right.
have to give repeated, every day you have to give two 15-second stimulations of low level red light. So 1 minute you have to sit, it will
Right.
give stimulation, and there will be an after
Uh-huh.
image which is very strong, and again they will give.
Okay. Got it. Got it. So from hyperopic blur, you are inducing myopic blur
Yes, yes.
by giving glasses. Okay. Thank you.
Sir, any visual field restrictions that these children have with glasses
So
practically?
yeah, so what happened was when these glasses came, I obviously they came. I was the KOL for Essilor and then for Zeiss. When they launched the glasses in India, I was very much interested for both my kids to have glasses. So we got the glasses, and then I thought that whether 9 millimeter is sufficient or not. And so what we did was the first 10 patients in whom we prescribed these glasses, we did 24-2 and 30-2 in them. 24-2 was very straightforward. There was no blur. 30-2, some points they used to fumble, and I felt that it was mainly because they were not able to uh, uh, get it. But otherwise, 24-2 was absolutely clear. There was we have the fields of those times when we prescribed it for the first time. 24. So what it means is that at least 24 to 28 degree central field is not affected.
Right, correct.
But if we go in more periphery, like 40 degrees, 50 degrees, yes, there is definitely peripheral visual field problems. If you tell the patient to go with this and start playing some games initially, they don't realize that they have to move their head, and they may try to see from the periphery and may not be able to see the periphery. So in those sittings, sometimes we do tell them to make single vision glasses, and they can use them when they are going outdoors. And gradually, they do understand that if they have to see a little bit of periphery, they have to move their head. So that is definitely a challenge if we look into a very large field.
Sir, if a patient has exotropia and is wearing the glasses, would the peripheral, the degrees change when you're doing a, I mean, because the focusing if you are doing with one each eye individually, it should be central. But in most actually, when you are in real life, one eye is always going to be exotropic
If there is
to a smaller
constant,
degree. Yeah.
no, if there is constant exotropia, then it will not work for the eye which is exotropic. If there is constant
Yeah.
exotropia, it will
Okay.
not work for that eye which is outside,
Okay.
or for esotropia also. But if it is intermittent exotropia, whenever both the eyes are straight, it will work for them.
Okay. Okay. And you had also mentioned about the multifocal, the progressive glasses in
Yes.
your presentation.
Yes.
So I was trying to apply that to a contact lens, which is a multifocal contact lens. Normally, we get the center near segment, this thing, but I think nowadays we get the center distant contact lenses also. I think Cooper Vision, or I think they have that. Would that also work in a similar way by prescribing a center
Yes.
distance contact multifocal?
So yes, it can work. It can work if the principle is same, it should work.
Oh, yeah. Thank you.
So, so if there are no questions, we can close the meeting. Next, we can either talk about ortho K red light or about combination therapy. I will upload the video in a couple of days. ठीक है?
Thank you, sir.
Okay. Thank you.
Thank you, sir. Yeah.